everyone, and welcome to today's presentation. And I'm just going to tell you right now, you're in for a treat. We have a fantastic guest, someone that is I love talking to any opportunity I get a chance to. And we talk about lots of things, not just people with intellectual and developmental disabilities. We talk about where we live, the tools we have, all of that kind of fun stuff. So, but today we're going to be focusing on top concerns as people with IDD age. So really briefly, you guys probably know who I am. I'm Craig Escudé. I'm a family physician. I've spent the majority of my career providing healthcare to people with intellectual and developmental disabilities as medical director of a regional center when I lived in Mississippi. I retired from that clinical practice in 2018 and began to work with Intellectability. We are a company that provides tools and training to state agencies and provider organizations and others to help people understand health risks, to identify health risks that are often missed, and to improve overall health outcomes. We've got some courses and books and health risk screening tool and lots of other things, but I do want to just put in a quick plug for the IDD Health Matters podcast. Pam, who is our guest today, recorded an episode with me, and it's actually going to be sent to you in the follow-up email. But I'd love for you to take a look at the IDD Health Matters podcast. We interview lots of people from the field. And so now I'm going to turn it over to our wonderful guest and dear friend, Pam Merkle, to tell you a little bit about who she is. Welcome, Pam.
So, my gosh, thanks for having me. I love working with you. I have mad respect for what you do. And I think, being able to blend, and everybody that's on the podcast also being able to blend and learn from each other makes us a stronger group of folks that can support people with developmental disabilities as they age. So I'm supposed to tell you who it is I am. So my name is Pam Merkle. I am the executive director of the Association on Aging with Developmental Disabilities. I've had this job for like 30 years. And it's crazy how it is I got here because I wasn't not supposed to be here, right? So first off, Association on Aging with Developmental Disabilities is a really long name, goes by AADD, and it's about blending the aging with the developmental disabilities world together to provide the best supports and services we can to help people successfully age. So I started out in healthcare, bottom of the rung, needed a job. That's how I put myself through school. Worked my way up. I ended up reading cardiac monitors in ICUs. I loved it. It's like fishing, you get a little PVC, you got a little bite. It was fun. I moved back to St. Louis, where I'm sitting in this chair, back to St. Louis, and followed up working at one of the major hospitals and was working with the meanest nurses I've ever worked with in my life. Oh my God, they were past evil. And so it was in the 80s. So I trained to be a nursing home administrator because I really like old folks, or I did. The closer I get to being old folks, then that's a little, I'm looking through different eyes. That being said, oh my God, those nurses were mean. And every time, because it's the 80s, and for you that are young, probably don't have an understanding of when you got your paycheck, you bought stamps. And you put stamps on every resume out for me to get out of there. So I've sending out resumes. If somebody would offer me a job that made $12 an hour as a ditch digger, I'd be the best ditch digger we ever met. And that's how I would have ended up. But the guys that answered my resume were folks that were in the developmental disabilities field. And in I come out of the healthcare field into the developmental disabilities field. Healthcare, you fix stuff. You're presented with an issue and you figure out how to fix it. And in the DD world, in our world, then what? We teach hard as we can, and look for as much independence with somebody as we can do. And I was immediately in trouble, right? Because I was asking, why are you making these people cry? Why are they so upset? And I thought that we could fix things. And over time, I learned about the teaching and being able to support folks. And then as time goes on, so I had 10 years in healthcare, 7 in developmental disabilities, and then this job opened up. So bringing the aging and DD world together, and then with my educational background, with like a minor in gerontology, then I was positioned to grow a company that was about $30,000 to like a $2 million piece now, supporting aging people with developmental disabilities in St. Louis. Best company ever. So I think that's probably enough about me.
Thank you, Pam.
Yeah, like what I do. We're good at it, you know?
Yeah, thank you, Pam. And like I said, I told you you're in for a treat today. So let's get moving. And Pam, I like to start with a quote. And this was a quote you said when we did the podcast. You meet people where they are at and support them in the growth areas that they need in order to achieve the best independence that they can.
Yeah.
Elaborate on that a little.
Oh my God, I read that when you sent me this slide, and I thought somebody's really smart said that. Okay, yeah, yeah. So but you can't interact healthily. You can and do well with anybody that you're thinking that you're better than, or you're thinking that you're not as good as. But you meet people where they're at and try and open up communication to find out what it is they need, how you can work together and help each other out. And then everybody grows together. But meet people where they're at. Listen to what they have to say. Pay attention.
I
So I
love
think
it.
that, yeah, I think that's what I was thinking.
Yeah, I love it. And we tried to do that. So we asked people what were their top concerns. We asked people with disabilities. We asked people who work in the field. What are the top concerns that they have as they get older? So we did this survey, again, people with IDD who were aging, and then also people who work in the field. And here are some of the things that we found. There were some main categories, and then one big one at the bottom you see there that we'll talk a little bit more about. But some of the big categories, people were concerned about dementia and forgetting things and not remembering stuff. And people were also concerned about depression, about health problems, about loneliness. And one of the things that was kind of surprising to me was they were actually concerned about some of the long-term side effects of medications. Um, the first thing that I want to point out, and Pam, I'm going to ask you to talk when I go to the next slide about loss, but some of the things that I want to point out here are that these are the same concerns that everybody most likely has. They're concerns that I have. And that's so important for us to recognize that people with IDD have the same concerns, the same uh, likes, desires, and wants for their lives as anybody else. And I always think that's an important point to make. But the other things that they mention here fit into that big word at the bottom, loss. And it's loss of a lot of different types of things. So Pam, do you want to talk about some of the things that people are concerned about losing?
Oh, yeah, I mean, part of it isn't aging, okay? And I think I read somewhere that our population has the greatest amount of loss than maybe any other cultural populations, and that's
Mm,
adding in. So, we're losing our parents, we're losing our health, we're losing our vision, we're losing our community access. You can see this slide, we're losing all that. And then if we have support staff around us, then we lose more people because of staff turnover, which is
yeah,
kind of a goofy kind of thing. Yeah,
yeah.
yeah.
People mention loss of function, their own ability to function, hearing and vision. It's something I always stress. It's so important to think about, things like hearing and vision, especially in a person who doesn't use words to communicate. We need to recognize that, how all of us who, when we hit 40 or so, start having trouble seeing close. And that can affect a person's ability to interact with their environment and so on and so forth. So those things are always really important to consider. But people were concerned about losing family, their supports in general, and the support services that they might have, losing friends, losing their independence, losing their health, losing their home, losing where they live,
Everything.
losing access to others and to people in that they relate to in the community, or being able to get out as much as they used to. And another one that I was a little surprised to see was ability to recognize emergency situations. They
Yeah.
recognize that, hey, I might lose that ability there. Now, Pam, before we go into some of these in a little bit more depth, I know that the program that you were with um, has developed some great ways to help maintain independence as people get older. And I really would like you to share a little bit of that.
Well, so check this out. I mean, I believe in being proactive versus reactive. Proactive is you're going to do something up front that's going to support somebody to do something better. Versus reactive, you didn't do what it is that you were supposed to do, and now they're in a nursing home. They're in the emergency room time and time again because they didn't get the supports that they needed to do healthy aging. And it's, so I've got 48 staff, and it's in teaching them to understand why it is what we do is so important. I cook up things that will hang in your head, right? So
Mhm.
the latest is like the healthy recipe for aging. It is all the junk that our teachers taught us, that our parents taught us, that said, if you do this, you should remain a pretty healthy person. And so every time that someone is with us, we're doing some element of exercise. We're doing some element of nutrition. We're doing some cognitive stimulation therapy. Use your brain so it doesn't turn to mush. Friendship development is a big deal. If you don't have a friend, that equals loneliness, and nobody tells on you when you falls down the stairs because you didn't pick up the phone and say, Mary, I fell down the stairs, and she says, ooh, you need to get to the doctor or I'll call somebody for you. So that loneliness friendship is a big deal. Identity. I tell you, I've been doing this job for 30 years, and I look at my guys, and they're all a little older than me, not a lot, but they look old, right? And so when we look at identity, when I first got to start working with them, that they just looked at their laps and they cried. They responded yes to everything. So to build an identity where somebody says, I am this. I am, first off, all my people, we start aging at 50 because of the social game, but I am a senior hotshot. They named themselves. I am a senior hotshot. And then we work on skills that give them identities that they care about. I am a fisherman. I make hats for newborn babies. I'm an artist. I am somebody. And so the people that I get to support, there's where, we look at that identity piece. In that goes to reminiscence. Where did you come from? And then the whole anti-loneliness and matching people with people to develop friendships. So every time we're out, doesn't matter what program I'll tell you about, we're doing these elements. And so if your listeners out there do those things, that it should also help you age more healthily than if you didn't. So
Pam, and I'll tell you, I've met many of the people that you work with when I attend the conference, and a plug for the conference, the AADD, Association on Aging with Developmental Disabilities conference, every year in the St. Louis, St. Charles area. I would recommend that you look it up. It's a great conference to go to, and you get to meet Pam in person. But I've met a lot of people that you work with, and they have a presence
they're
about
different.
them that is different.
Yeah.
They are definitely engaging. They're outgoing. They're interested. They have identities. It's clear that the work that
Yeah.
you do has a positive impact in their lives.
Yeah. And
Yeah.
from a health perspective, I mean, decreasing visits to the emergency room because they have the supports they need and the education they need in order to maintain their health, or to ask for help, or to know that there's somebody there that also is watching over them as they're watching over us.
And
So
yeah, you mentioned decreasing emergency room visits. Not only
yeah,
is that great for the person, okay, not to have to go to the ER or be hospitalized if it can be prevented, right? But think about it this way too. There's a lot of costs associated with going to the emergency department or being hospitalized. And if we can prevent unnecessary hospitalizations or emergency department visits, we can also reduce overall costs. And as we know that's what's floating around right now, don't we, about the
mhm.
changes and cuts in Medicaid budgets. And so it's important to do things that can not only improve health and improve outcomes, but also reduce unnecessary expenditures. And one of the handouts today, by the way, which there are a couple of handouts for you to download if you click on the handout section, one of the handouts is a brand new white paper that we just came out with about optimizing healthcare and home and community-based support expenditures at a time of Medicaid cuts. So download that handout. There's also another handout in there about some aging tips as well too. So please take a look at those. So let's go on and talk about some a little bit more specifics in some of these areas. And really what I want to focus on is, what can we do as supporters? What are important things that people who work in this field, what can we do, for instance, with this slide here, cognitive decline and dementia? We know that that's a concern. What can we as supporters do, Pam?
Well, I mean, obviously, we're talking to our people, and we're watching. And they're looking at us also, looking for any kind of changes. There's
Yeah.
assessments that we can do. Sometimes I think in my job, the phone will ring and somebody will say, I think they're developing dementia, and then I'm actually trying to back them out of it because there's health things that can look like dementia.
Yes.
If you take somebody's hearing and vision away and that's not addressed, then they're like, here, take somebody's hearing, chances are they're either going to be very, very quiet and very sullen and not respond to you, or they're going to be the clown and they're going to answer you back in some of the funniest things that you ever heard because they didn't hear you. And then people say, oh yeah, they're off. There's dementia going on there. And so half the time I think that I'm trying to back away from a diagnosis until truly it's a true diagnosis to do rule out medical when we're looking at cognitive decline and dementia. Does it take us a while as an older person to sort through to be able to respond to a question that was asked? Yeah. Do they have the physical ability to do that? So that again goes to rule out medical. So
Pam, you took the words out of my mouth when you're talking about ruling out medical causes. I talk
it's a
about that
big deal.
all the time
Mm,
when we see changes in behavior, including changes that may look like dementia. We always
they're
need to
not.
look for treatable underlying causes. And when I do talks on dementia specifically, we address many of the preventable, or not say preventable, but identifiable underlying causes that can appear as dementia. And you're right, hearing loss, vision loss,
Big
some of the medications people take can
depression.
be problems, depression, mental health
Yeah.
conditions can look like dementia, but they may not
Yeah.
be. So, yep, carotid, yep, all
Yeah,
of those.
I got called in to do a consult one time. They were all upset with the lady who was making a peanut butter jelly sandwich. She got upset and she changed of behavior, went after the staff with the butter knife. Oh, she's on her way to the nursing home, so it really is ruled out. And her carotids were occluded, right?
Yep,
She got that taken care of. She went back to her baseline. How
there you
cool is
go.
that? Whew,
Great.
Wardum. Yeah, so I try and stop this one a lot.
And it's a matter of supporters thinking in that way, saying, wait, before we say this person has dementia, let's look and see if there's something underneath there. Now, let's
Yeah.
say the person has been ruled out from a lot of these preventable causes, and we are seeing things that look like dementia. One of the ways to identify it that we need to think about is especially again in people who maybe don't use words to communicate, is to look at their overall level of function and see if that is changing over time. And there's an organization called the National Task Group on Dementia Practices in Intellectual and Developmental Disabilities, thentg.org, that has some assessment tools specifically to help identify if someone might be showing signs of dementia in people with intellectual and developmental disabilities. So highly recommend that you take a look at that everyone listening take a look at that. But so again, being observant, and if we see these changes and we do have a diagnosis that it is dementia, some other things that we can do, or what are some things that you do, Pam, when you see people that definitely do have dementia?
Well, obviously, I mean, using the visual supports and memory aids, and my gosh, and continuing to practice on even games, that are consistently to help people use their brains, but and the memory aids are some of the same ones that you use if somebody's got like a traumatic brain injury.
Yeah.
So cues that will trigger somebody to remember what their sequence is in order to do a task. The other thing that I would ask, personal pet peeve, is sometimes, so the dementia progresses and they do need to go to a more restrictive environment. If we could minimize what those moves look like and looking at transitions and looking at trying to maintain consistent staffing. And I don't have an understanding why it would be in any environment with someone with dementia, they think it's a good idea to move them around. You know, why would you move
Change
them to,
environment or move.
oh my
Yeah.
God.
Yeah.
Yeah, how the sun comes up, how your bed faces the window, who the new staff are. Yeah, that floors me, and I don't even have that label yet. It's coming, but yeah. Yeah, so yeah, don't move them. Use cues that they're familiar with. Keep
Yep.
familiar faces with them. Run their routines.
And I do want to stress hearing because there are studies that show that when you lose hearing, the rate of decline in dementia is much steeper. You lose a lot. And when you correct for hearing losses, for instance, if you provide a hearing aid and you can correct for hearing loss, the rate of decline actually slows and can level out. So it's really, really important to address hearing loss as well too, if you have someone that you're supporting that has dementia.
Can
All right.
start by cleaning their ears, like looking for earwax.
Yep.
I was with a man yesterday, you know, and I thought he's mumbling. This is different. And he already had a plug in his ear once upon a time that they removed. So I'm going to assume that it can, you know, it'll continue to
Yep. I
produce.
see that all the time.
Simple.
Many times it's just earwax that has a
Yeah,
significant impact. We call that cerumen impaction. Um,
funny.
Terrible joke there, but I tried. Yeah, so very important to look at the simple things first. All right, let's talk about depression and mental health. There were some current concerns about that too. What can we do as supporters if we are supporting people that are either depressed or have other mental health conditions or diagnoses?
Yeah, I mean, try and you can take a look at why it is that. So sadness and depression, two different things. So if we look at sadness as a precursor, we can look at how it is that we can find out and help that person do things that are more happy to them. If we look at depression, then that more is about rule out medical, seeking treatment, trying to figure out what it is, either through therapies or through medications, that's going to shore the person up so they can go back to a cognitive baseline that's not skewed by the depression.
Yep. You know, something we're hearing more and more about too is the impact of previous trauma in our lives and trauma-informed care, trauma-informed supports. And when we talk about trauma and trauma-informed care and supports, there are really three big factors that can help people heal from those things. And one of them is for them to feel safe, to feel that they're in an environment where they feel safe and that they can talk about what's going on. So having people that can listen to them as well too. Another thing is connections, facilitating those connections, helping people becoming more involved with other people. When we connect with people, we can share more, and that can definitely help with past traumas and some, sense of loss or depression, things like that. And the other aspect is so what is it? I'm forgetting. It's safety. It's facilitating communications, and empowering people to have a decision and a
Of course.
choice in what they do in their lives. And sometimes we do lean too heavy on what we think people need for their lives, but we need to ensure that they have the option to participate in their lives and what happens to them, and empowering them with that ability is very important as well too.
Meet them where they're at.
Yep. All right. Another big concern is health problems, and
Mm.
we touched a little bit on that, but what can we do as supporters for people that are experiencing health problems as they age?
So obviously, I mean, here we're ruling out medical. I mean, some of it. So healthy aging is not necessarily bad. The insults that come on us, that are maybe because of genetics, maybe because of an injury, those are kind of different kinds of things. But it always is. You're looking at any kind of behavior change, any kind of communication change, ruling out the medical, being proactive about it, making sure that people get their screenings. Um, Ahead of time, and when it, and talking through those, like go with them, explain to them, don't send it by themselves. um drugs are like, here we don't want to see anybody that are taking medication more than 5 is what we're trying to narrow down, and that includes the over the counter medications. So medications can have like amazing effects on people, they can have amazing really negative side effects, and sometimes the having whatever it is, whether your knee's hurting, it's almost better to find something different to stop that knee from hurting from a medication because of the side effect.
Yep.
So having staff also know how to support the person in a medical appointment. We had a
Mhm.
really cool project here a few years ago we called it geriatric assessment through St. Louis University, where we went in with a one-on-one support model and met with the doctor one-on-one, and the doctor did a non-invasive, assessment of the person. But what we found was the doctor couldn't communicate with our person. They were warm, loving people. They were amazing, but they weren't asking the right questions. And our guys, were trying to give them information. So the staff facilitated the language barrier between the doctor and the person, and it was a win-win. I mean, so it was a really kind of an amazing thing. So
Pam, that is so incredibly important. And we actually focused one of these IDD Perspective webinars a couple of 2 or 3 months ago, focused specifically on that topic. And you're always asking me, okay, what are you going to talk about next year at the conference?
I'm asking you, yeah.
That might actually be a great thing to talk about. So I'm glad we had this conversation.
Yeah,
So
for the docs out there, you can't help them if you can't figure out what they're trying to tell you.
you're right.
And
Right.
they can't do what it is that you ask. They can't do what you ask if they don't understand you.
Yeah. And going back to preventive screenings, we know that people with IDD have lower rates of preventive screenings for things like breast cancer and prostate cancer and colon cancer and things like that. So we as supporters should advocate for the appropriate screenings that are appropriate for any person at whatever age they are, so we can do that. And I love that you brought up medications, because that is so important. And the average, what is the average number of meds people with IDD take? It's like 8 or 9,
10,
or maybe even more than that.
It's ridiculous.
Yeah. And when you get above 5 or so, you have a huge chance, almost 100% chance of having some interactions. And then, thinking about promoting good health, help things that keep people healthy, keep people mobile. All of those are important too as we age too. So all great.
Oh my gosh, one of the things that's happened a lot with us right now is, a person comes in and maybe they're a little wee wobbly, and instead of prescribing like physical therapy to regain your strength, we're getting a whole bunch of walkers, and encouragement to sit in a wheelchair. And again, in this organization, we're figuring alternative strategies, because like I've got a guy they gave a walker to and he's tripping over the walker, and he's more of a fall risk because of the walker. But I think the doc doesn't know what to do, and so they're giving out these walkers freely, where it's another thing as a provider that we can try and help ward off by doing more proactive things with physical therapy and building up strength and endurance and practice and the anti-fall risk kind of things, instead of them having to sit in a wheelchair and be destined to have that for the rest of their life.
And another thing related to screening that someone brought up in the question section here is, what about screening for menopause and hormones and all of that? That's a piece that's often overlooked in people that we support. So another good thing to talk about and advocate for. All right, what about housing and living arrangements? What can we do?
Oh man. So right now, St. Louis is in a housing crisis. 30 years ago, the government said, hey, builders, we'll give you dollars if for 30 years you can hold in your apartment buildings that you've built, 30 years that you'll accept federal funding to support seniors or people with disabilities who need it. And 30 years has gone by. And so our housing now is going fair market rate, which means our guys can't afford it. So that ends up being pretty frightening, because one of the proactive things that we did years ago was, when the person was eligible, we moved them out of kind of drug-infested neighborhoods, because that's what they could afford, into housing where they had the supports. So start planning early. We're trying to plan now, like what's going to happen if, say HUD certificates start getting pulled, what are we going to do? But in any transition to any other different kind of housing, you really are trying to explore what's the best non-restrictive environment that a person can be in that makes them happy, that they're part of the planning process, that hopefully their caregivers can shift with them because it's not as a tough a spot, that they're just, mostly that they're a big part of wherever it is they're going to make that transition to.
Yep. Living and housing can be scary, certainly. And doing whatever we can to address that, aging in place options, building relationships when people do have to move. I think it's helpful to build relationships or transition it slowly if you can, to give people time to adjust and learn all of these new environments as well. How about loss of routine, friends, and staff? What can we do?
I think that's here. They're all very important things when we look at the age-related changes, but I think this is a big one. I mean, it's the thing that's going to hit us all. We've got projects that are on anti-loneliness and friendship development, but the loss of friends, and again, if you don't have somebody checking on you, it doesn't matter if you wear a label of a disability or not. You are not going to thrive because you're going to be sitting, alone in your home. If you can support people early on in the areas and help them develop friendships and daily routines, that's a winner. Also the familiarity and the humanness towards each other is, um and it also goes to the identity piece. People are going to be friends with people they have commonality with, and so being able to bridge a gap where people can tell their stories and there's something similar that they can talk about to help develop friendship, even though as we age, the biggest thing our commonality is going to be health, right? So you can take the richest person in the world and the poorest person, and they can have a conversation as we age. For those of you out there that have a tendency to be isolated or be alone, but you can have a conversation based on your toe hurting, or whatever
With
commonality is
anybody.
that you have. Oh my gosh, yeah.
And the older we get, the more of those conversations we have,
Oh,
don't we?
they're
Oh,
so.
my toe hurts. Oh, my
Oh my.
knee hurts. Oh, my back hurts.
Oh, my hair's coming in white, and I can't see it to pluck it anymore. Oh, yeah, unfair.
Yes. All right. So continued support, maintaining structure when we can. And, sometimes there is loss that's experienced and we can't fix everything and we can't change those things. So helping people, grieve when that's needed as well too, and working on ways to support people in doing that. Now, this next one is, as people who know me know, this is a big one for me. A concern about finding healthcare providers, and I will already tell you there are 2 or 3 questions that people have popped up related to this one. How do we find healthcare providers that are trained to meet the healthcare needs of people with IDD? So I'm going to let you take the first shot at that, Pam.
Oh my. All right. So yeah, I'm pretty picky on who I hire. Okay, we'll start there. And I told you I came out of the medical world, and then I learned from the developmental disabilities world. I'm actually looking for people who have both of those. What I learned in the medical world was really how to use all of my senses in order to take a look at the person. And because we talked about rule out medical, it's a big deal. If all of a sudden, you've got a skin color change, you have a different smell, you have a different movement, so looking at the healthcare perspective, a component, and looking at the educational component of teaching people to be independent, I'm looking for that blend of people. So it's actually going to be maybe one of the next big rants that I write. In Missouri, it has to be. So I told you I started at the bottom. I started as a certified geriatric nurse's assistant. So my specialization was in geriatrics because I like older folks. So I had that, and then I don't know why then you couldn't have a certified developmental disability nurse's assistant component, but it has to be something that goes through the legislature, because it's a certificate. So I'm looking for that, and I would probably hire that person because of that educational component. But I also look for folks who came up with not a lot of resources. So whether they came up on a farm is a big sell for me. If they came up where they didn't have a lot of money, that's a big. I'm looking at you. If I see on your resume you were a Girl Scout, a Boy Scout, you did some kind of service, then I know that you think in a way that's about service to your fellow human beings. I'm looking for you. Matter of fact, I'm hiring right now. I'm in St. Louis. I'm hiring right now because I'm having an expansion of contracts, whatever, because I don't have staff turnover, because I try and hire people that also match the people that we get to support. like with me, maybe you can see me wiggling around in my chair. If you put me in a cubicle, I would die, right? I need to move around and be zippy. So if you put me with somebody who doesn't move around as much as I would, first off, that person would be looking at me moving around and I'd be getting in trouble, right? So to match staff with the people that we get to serve, support is a big deal. I also hire through word of mouth, you know, and I try really ethically not to steal. If I see somebody,
That's
ooh, I
good.
think they would fit within my culture. But yeah, so my staff find each other.
So
So that helps.
I'm gonna add some to that in terms of healthcare provider staff, and I'm gonna let everybody know about something that is out there. You mentioned like nurses and certification. Guess what? The Developmental Disabilities Nurses Association
Yeah.
actually does provide certification for both RNs and LPNs in IDD. So a certified
Mhm.
developmental disabilities nurse is out there. So I highly recommend that you look at
Great.
ddna.org and
Yeah.
learn more about that organization. But besides that, physicians, there is a physician group that's similar. They don't do certifications per se, but it's the American Academy of Developmental Medicine and Dentistry. But when we're talking about finding in our own communities a healthcare provider who understands people with IDD, and then you
Mhm.
add to that people with IDD who are aging, that can be very, very challenging. And that is something that I'm just always working for and advocating for. And we unfortunately probably have to help train them up sometimes. A lot of us are working to incorporate IDD specific training into medical schools, nursing schools. I actually developed an e-learning course specifically to train healthcare providers on the fundamentals of providing healthcare for people with ID. That is being incorporated into a few nursing schools, medical schools. We'd like to see it expanded. It's also being used by clinicians all over to receive this training. But we need to do a lot more. We need to advocate for policy changes in the accrediting bodies for medical schools, nursing schools, and others to say, yes, you have to teach clinicians how to provide at least a fundamental level of competent and compassionate healthcare. And sometimes you guys are the experts. You may not be a physician or a nurse, but you understand health in people with IDD. And you can train others, you can help people grow, provide them with resources that they can help them grow to be better healthcare providers in this field. I do think in terms of this, how maybe a supporter, a direct support professional, or a nurse who works in a program who understands this field can train people is by guiding them along the process. Sometimes here's a story of a very, very true and very real story about myself. When I was in residency, I was moonlighting in a clinic, and someone came into the office for me to see them. They were in a wheelchair. They did not use words to communicate. They had cerebral palsy and multiple other diagnoses, and the person's mother was with them. And her mother, the person's mother, was so kind to me because it was clear that I didn't even know how to start this interaction. And she guided me along and told me the things I should be thinking about and the things that, well, a lot of times when he has this behavior, which is why I brought him in, it's because he's either constipated or he has an ear infection. And I really just need you to take a look in his ear because he is having good bowel movements. And she taught me. And that was so impactful for me. It was also very humbling because I should have known how to do this, but I
Yeah.
wasn't taught how to do it. And so it's not always that healthcare providers don't want to. You know, we don't know what we're not taught. For instance, I'm not taught how to do cataract surgery. So if you came to me for cataract surgery, you will go blind, you know. But the things that I am taught to do, I understand. And so that's why education is so important. Sorry to jump on my soapbox about that, but that is a huge one for me. We're coming to the end of our time here, and I want to get to a couple of questions. but I think everybody can see why I said you're in for a treat with all of the information that Pam has shared, and she has so much more that she can tell us about. There's no doubt in my mind that if you want to learn about how to support people who are aging, reach out to AADD, Association on Aging with Developmental Disabilities. Lots of resources and a great conference there. I want to again point out, call attention to the handouts. This is from the Clinical Pearl book. Clinical Pearls in IDD Healthcare. It talks about aging with disabilities and has some tips there for you, as well as a survey that we'd love for you to take to provide feedback on future topics and how this one went. Another handout is that new white paper I mentioned on optimizing home and community-based services and healthcare spending for people with IDD during a time of Medicaid cuts. Download that, share it with anyone that you like. I do want to mention the health risk screening tool that we have at Intellectability. It identifies health risks in people with IDD at any time in their life, including as they age, and things that we see as people age. And it's a great tool to help identify those health risks and provides action steps for supporters to take to help mitigate those risks. If you'd like to learn more about it, reach into us at replacingrisk.com, visit our website. Again, I encourage you to provide the feedback from the survey link that is in the survey. There's a quick scan for you that you can do to get to the IDD Health Matters podcast. And that brings us to the end of the presentation. We did answer some of the questions. I'm going to stay on for another couple of minutes and scan through the questions and see. Okay, somebody asked, what was the task group with a long name that's about preventing dementia in people with IDD? And I think I popped that into the chat, but it is, it's the-ntg.org. If you look up dementia practices or dementia screening and intellectual and developmental disabilities, they will come up. And it's a great organization there. So great. Pam, I'm going to ask you this one here. Any creative ideas to assist people with hearing loss who refuse to wear their hearing aids?
Any creative ideas? Oh my gosh. So yeah, how many hearing aids have we seen go down the toilet?
Yeah, right.
Yeah. Creative.
She does mention they're trying to do some desensitization to help the person get used to them. So I guess you could start off maybe with something really soft, like just a simple earplug that people could learn that's more comfortable than maybe a hearing aid would be. And I don't know if you have other thoughts on that.
I would also maybe find a staff who also wears a hearing aid.
Great.
So again, so why they may not be wearing it because it's bothering their ear. They may not be wearing it because it's a stigma, so yeah, I mean, so put them in environments where that they see other people and that it's a fine thing, and ensuring that they know how to use it, because sometimes if you turn those up, they're picking up all kinds of other side noise, and it's horrible. So making sure that they have the right hearing aid that fits them, exposing them to other folks who are also wearing them, so they're just another one of the gang. And then if it is something that they're feeling, desensitize them to that. That would be what the first things that I'd be thinking. And then tonight when I'm going to sleep, I'll probably come up with something else.
Yeah. All right. Somebody asked about supporting older workers with IDD to continue working if they wish, as long as possible. And what are your thoughts on that? People working if they want to work?
I think if people want to work, they should absolutely work. I would like to think, and so yes, and so I mean, we've got little 70-year-olds that are still out there working, but I'd like to think that what it is that we can provide also in teaching people to retire, because I've got a whole program about that is going to look much more inviting than going to work every day. So what is it that they get out of work? Is it the paycheck that they're making, or is it the socialization, or is it that's where their friends are, and so we have opportunities here where people actually rush towards retirement because it's more exciting.
Yeah.
So, but absolutely, if you want to work, you know, until you're done, go for it.
Go
Because
for
Lord
it.
knows
Yeah.
we need you. We need you out there working.
All right, I'm going to touch on one more question because I think this is a very interesting question, and then we'll end after this one. Um, but it's in regards to relationships and connection, particularly sex and sexual relationships. Now, that is a whole other topic, I will say, and we could talk for hours on that. And I actually do a training on sex and people with IDD. But I'm curious, Pam, how does that get addressed in people you support?
Well, I mean, you're trying to support good, healthy relationships. You know, I mean, so relationships aren't always about sex. You know, so I mean, it's making sure people have the tools in order to interact in a healthy way. And I think if they're their own guardians, that would be the only barrier that I see. That we're all human. We are all have the same feelings, that supported, educated, that the people have the tools to do things safely in a warm and loving way. How's
Yeah,
that? You're
yeah.
ending with that question, really?
I did. I am ending with that question. I thought
Oh
it would
my gosh,
be fun
buddy.
that way. We thank you all for joining us today. There were lots of great comments in the questions and all of that. I appreciate you joining us. You can download this PowerPoint in the handout section as well. So if you wanted to scan some of the QR codes or whatever those are, you can download this presentation. You can always reach out to us. Visit our website at replacingrisk.com, and you will be emailed this the video about an hour or so after the presentation. So if you didn't get a chance to see something or want to listen to something again, it's there. So and somebody asked, what is the podcast called again? It's IDD Health Matters podcast. So again, thank you all for joining us. Pam, thank you so much. It's been a
Thank
great
you.
pleasure talking with you,
Thank
and
you.
I look forward to seeing you at the next conference.
All right, that's May 11th and 12th, you guys.
May 11th and 12th, St. Charles,
Yeah,
Missouri.
yeah. It's a good one. Thank
All
you
right.
for having me. Thank you.
Take care, everyone.
Bye.